Every morning, hundreds of millions of people over the age of 60 swallow a small white pill and trust that it is keeping them safe. The number on the blood pressure chart goes down. The doctor nods. The visit ends in 5 minutes, and nobody looks at the ankles. Amlodipine is the most commonly prescribed blood pressure medication in the world. It is cheap, it works quickly, and it produces numbers that make charts look clean and doctors feel satisfied. But there are things this pill does inside the body over 5, 8, 10 years that never come up in a 3-month checkup. Not because your doctor does not care, because a 5-minute visit cannot hold a 10-year story. And the pill is inside your body every single day. What happens on day 1 of taking this medication is very different from what is happening in year 7. The pill your liver processed easily at 50 is being handled by a slower, smaller liver at 75. The dose on the bottle has not changed. The dose circulating in your blood is a different story entirely. And the swelling in your ankles that your doctor calls a common side effect is not the problem. It is the alarm. The question nobody has asked you is what that alarm is actually warning about. Consider a woman named Frances. She is 72 years old, a retired librarian who spent 30 years organizing knowledge for other people. She cataloged every detail of her professional life with precision, and she brought that same precision to her health. She kept a notebook with her blood pressure readings, her appointment dates, and every medication change her doctor made. She was not the kind of patient who missed things. Frances had been on amlodipine for 8 years, 10 milligrams every morning, taken with a glass of water at the kitchen table before the sun was fully up. Her blood pressure at every visit read somewhere around 120/78. Her doctor called her a textbook case of well-controlled hypertension. But Frances had been watching something change in her body for 6 years, and every time she mentioned it, the appointment moved on before the conversation could. It started in year 2. By early evening, her ankles would look slightly puffier than they had in the morning. She elevated her legs at night the way her doctor suggested. It helped for a while. By year 4, the puffiness was there when she woke up and worse by sunset. Her doctor added a diuretic. The swelling did not go away. The dose of the diuretic was increased. Still, the swelling stayed. But now Frances was getting up 5 times in the night to use the bathroom, and her potassium levels on her blood work had started to slide downward. By year 6, the skin on her lower legs was shiny and tight and warm to the touch. Pressing a thumb into her ankle left an impression that held for nearly half a minute. Her sister visited that autumn and took one look at Frances's legs and went quiet in a way that said more than words. Frances kept telling herself the doctor was not worried, so she should not be worried either. The chart said everything was fine. She trusted the chart. What was actually happening inside her body had nothing to do with salt intake or prolonged sitting. Amlodipine works by blocking the calcium channels in artery walls. When calcium cannot enter, the muscle in the artery wall relaxes, the vessel opens wider, and blood pressure drops. This is exactly what the pill is designed to do. The problem is that the pill only affects one side of the circulatory equation. The arteries carrying blood into the tiny vessel beds of the ankles and feet open wide. But the veins carrying blood back out of those same vessel beds do not have the same calcium channels. The pill cannot reach them. They stay the same diameter they have always been. Now you have a situation where blood is rushing into a small space faster than it can leave. The pressure inside those tiny vessels builds. The vessel walls in that region are only 1 cell thick. They are not constructed to withstand sustained high pressure. The fluid component of the blood gets forced through those walls and into the surrounding tissue. That is the swelling. It is not extra water from salt. It is plasma being pushed out of blood vessels by a pressure imbalance the medication created. When a doctor then prescribes a diuretic for this swelling, the logic feels sound. There's fluid where it should not be. A fluid-removing medication should fix it, but the diuretic drains fluid from the bloodstream. The fluid already sitting in the tissue of the ankles is outside the bloodstream. The diuretic cannot reach it. What the diuretic does accomplish is depleting the blood of potassium and magnesium as it works. Potassium loss makes the heart's electrical rhythm unstable. Magnesium loss gradually stiffens the artery walls, which eventually pushes blood pressure back upward. The doctor sees the pressure rising and increases the amlodipine. The higher dose widens the arteries further. The swelling worsens. More diuretic is prescribed. More potassium is lost. A supplement is added. Sometimes a second medication is added for the irregular heartbeat that the potassium loss caused. What started as 1 pill becomes 2, then 3, then 4, with each addition treating the side effect of the one before it. This is what medicine calls a prescribing cascade. Frances had entered it at year 2, and by year 8, she was on 3 medications where she once had taken 1. But the ankle swelling, visible and uncomfortable as it is not the most serious consequence of this pressure imbalance. When a medication drops blood pressure, the body interprets the drop as an emergency. The brain does not know a pill caused it. It responds as though blood is being lost. The kidneys activate a rescue system designed to hold onto every molecule of sodium and water available. Blood volume expands, often by 10 to 15% over the course of months. That extra volume does not disappear. It circulates, and it arrives at the heart. The left ventricle, the main pumping chamber, is now being asked to move a significantly larger volume of blood with every beat, 100,000 beats per day, every day, year after year. The heart muscle responds the way any muscle responds to an increased load. It adapts. At first, it compensates effectively. But over years, the walls of the chamber stretch. They thin. The chamber enlarges. The pumping strength may remain normal on a standard test, while the chamber itself is quietly growing to accommodate a burden it was never meant to carry permanently. This is called cardiac remodeling, and it happens silently, without symptoms you can feel, without a single number on the standard chart rising to flag it. A blood pressure reading measures the pressure in your arm. It does not measure the pressure on your heart. A reading of 120/78 can coexist with a heart that has been straining under excess fluid volume for years. There's a blood test that can reveal this strain. It is called NT-proBNP. When the heart muscle is being stretched beyond its comfortable capacity, it releases a chemical into the bloodstream as a distress signal. That chemical is what this test measures. A normal result in an older adult is below 125. When a level climbs above that threshold, the heart is under strain. When it approaches 300 or higher, active damage is occurring. When Frances finally had this test ordered, her result came back at 360. Her heart had been signaling for help for years. A cardiac ultrasound, specifically examining the size of the main pumping chamber rather than just the pumping strength, confirmed that the chamber had enlarged and the walls had begun to thin. Her blood pressure readings had looked perfect for 8 years. Underneath those readings, her heart had been quietly remodeling itself to survive the chemistry of a medication her doctor had no reason to question. There is another effect of long-term amlodipine that almost no patient is told about. The same calcium channels the pill blocks and artery walls also exist in the cells of the gum tissue. When those channels are blocked, the cells responsible for clearing old gum tissue lose their ability to do so. New tissue continues to form. Old tissue is never removed. The gums gradually thicken, swell, and bleed during brushing. Most patients and most dentists attribute this to aging or inadequate oral hygiene. Dentists rarely ask which blood pressure medication a patient takes. Patients rarely think to mention it. The bleeding gums and the blood pressure pill exist in separate conversations that never meet. Frances had been told to brush more gently for 4 years. Nobody had connected the bleeding to the pill on her kitchen table. There is also the matter of cold feet. Amlodipine opens blood vessels, so logically the feet should receive more circulation, not less. But when the medication drops blood pressure, the brain responds by rerouting blood away from the extremities toward the organs it considers most essential. The brain and the heart receive protected circulation. The feet and the hands are deprioritized. The skin goes cold. The toes go numb. The fluid swelling in the ankles compounds this by pressing on the small nerves in the feet, starving them of oxygen and gradually degrading their protective coating. Tingling begins. Burning at night follows. This progression is frequently attributed to aging or to diabetes and is rarely connected to the medication causing it. Frances had slept with a heating pad at her feet for 3 years. She thought it was simply what getting older felt like. There's also the question of what the pill does differently in a body that is 72 versus a body that was 55. The liver is responsible for breaking amlodipine down and clearing it from the blood. In a younger liver, this process takes roughly 30 to 50 hours. By the mid-70s, the liver has physically decreased in size. Blood flow through it has dropped significantly. The enzymes responsible for processing this medication work more slowly. The pill taken on Monday morning may not be fully cleared before Tuesday's pill is swallowed. The pills accumulate. A patient who has been on the same dose for 10 years without a prescription change may be experiencing blood levels equivalent to a considerably higher dose. Not because anyone increased the medication, but because the liver that was supposed to clear it has slowed down and no one recalibrated for that change. This is why the swelling that was tolerable at 60 becomes severe at 72 on the same dose. The prescription did not change. The body processing it did. Certain foods and other medications interfere with the same liver pathway. Grapefruit consumption can cause amlodipine levels to spike sharply. Some commonly prescribed cholesterol-lowering medications compete for the same liver enzyme. When these are present simultaneously, the amlodipine clears even more slowly, and its effects intensify. Most patients taking this combination have never been told about the interaction. There are alternatives that do the same job without creating this pressure imbalance. Medications in the ARB class, such as losartan or valsartan, lower blood pressure by blocking the hormonal cascade the body launches in response to the drop amlodipine causes. They do not create the one-sided arterial dilation. They do not cause fluid to be forced into ankle tissue. They do not trigger the fluid retention that strains the heart. In the largest blood pressure trial ever conducted, involving more than 33,000 patients, the ARB alternative produced a significantly lower rate of heart failure than amlodipine. That study was published more than 2 decades ago. Amlodipine remains the most commonly prescribed blood pressure medication on Earth because it is among the cheapest options on insurance formularies, because it drops the chart number quickly, and because the system evaluating doctor performance measures that number. If an ACE inhibitor, such as lisinopril, is added to amlodipine rather than replacing it, it opens the venous side of the circulation that amlodipine cannot reach. When both sides are open, the pressure inside the small vessel beds balances out. The fluid stops leaking. The swelling resolves. The heart gets relief from the volume overload. This is the correction the medical guidelines recommend. It is not what most patients receive, because a diuretic is the reflexive answer to visible swelling, and a 5-minute appointment rarely accommodates the kind of reasoning that looks beyond the obvious symptom. Frances switched to losartan 11 months after her diagnosis. Within 2 weeks, the swelling in her ankles had decreased enough that she could wear shoes she had not touched in 3 years. The dent left by pressing a thumb into her ankle disappeared in seconds rather than persisting for half a minute. Her body stopped retaining the emergency fluid it had been hoarding, and she lost several pounds in water weight in under 2 weeks without any change to her diet. By the 6-week mark, a repeat NT-proBNP showed the level had dropped substantially. The heart had not reversed the enlargement yet, but it had stopped worsening. By 3 months, Frances noticed one morning that her feet were warm without the heating pad. She lay still for a moment to make sure she was not imagining it. She was not. The emergency rerouting of blood that had been stealing circulation from her feet for years had stopped, because the emergency was over. By month 5, her dentist remarked that her gums looked the healthiest they had in years and asked what had changed. When she told him she had switched her blood pressure pill 4 months earlier, he was quiet for a moment and then wrote it in her chart. He said he had never known a blood pressure medication could affect the gums. Frances told him she had not known either, and that perhaps he should begin asking his patients what they were taking. Her potassium, which had been held artificially low by the diuretic for years, normalized on its own once the diuretic was stopped. The palpitations she had experienced for 2 years, the skipped beats and flutters that frightened her while she read in the evenings, disappeared within weeks of her potassium returning to a healthy level. She went from 3 medications to 1. Her blood pressure on losartan read 124/76, nearly identical to what it had read on amlodipine. The same number on the chart, an entirely different body beneath it. The fatigue that had parked her in the armchair by 2 in the afternoon, the exhaustion she had accepted as the simple cost of being in her 70s, lifted. One afternoon, she looked up from her book at 3:30 and realized she had not moved to the chair. She had not felt the need. She called her daughter that evening and mentioned it almost as an aside. Her daughter said she had noticed Frances sounded different in their calls recently. Clearer, more like herself. Frances said she thought she was more like herself. She had just needed the right pill to find her way back. The afternoon energy she had written off as lost to age had been consumed by her body running a sustained emergency hormonal response to a medication for nearly a decade. When the medication stopped triggering the emergency, the hormonal flood that had been exhausting her every day receded, and the energy that had nowhere to go returned to her. At month 6, Frances drove herself to the market, walked every aisle, carried her own bags to the car, and sent her sister a photograph from the produce section. She was wearing the shoes she had not been able to put on for 3 years. Her sister called within minutes. Frances told her she had changed 1 pill. Her sister said that sounded too simple. Frances said it was not simple at all. It had taken 8 years, 3 medications, and a doctor willing to look past the chart number to find it. But the fix itself, once found, was 1 prescription. Do not stop amlodipine on your own. Blood pressure must be monitored carefully during any transition, and the switch to an alternative medication should be supervised with follow-up readings over at least 2 weeks. The safe approach is to work with your doctor, start the new medication the same day the old one ends, and track your numbers through the adjustment period. The conversation to have at your next appointment is straightforward. Ask for an NT-proBNP blood test. Tell your doctor you have been on amlodipine for several years and that your ankles have been swelling and that you would like to check whether the fluid shift is placing strain on your heart. If the result comes back above 125, ask for a cardiac ultrasound and specifically request that the technician measure the size of the main pumping chamber, not only the pumping strength. Then ask whether a trial switch to an ARB medication for 8 weeks might be appropriate, with the understanding that you will monitor your blood pressure at home and return for a follow-up. If the numbers hold and the swelling resolves, you will have your answer. If they do not, the original medication can be resumed. Bring the name of the long-term blood pressure outcome study to your appointment. Ask whether the elevated heart failure risk associated with amlodipine versus the ARB class has been factored into your current treatment plan. You are not challenging your doctor's competence. You are participating in your own care with information that did not make it into a 5-minute visit. That is not confrontational. It is responsible. Look at your ankles this evening. Press your thumb into the skin just above the ankle bone and hold it for 5 seconds. If the impression remains visible for more than a few seconds after you lift your finger, the fluid the medication pushed into your tissue is there. Your ankles are telling you something the blood pressure chart cannot. The chart measures a single number in a single arm during a single visit. Your ankles reflect what that number is costing your tissue and, by extension, what the volume driving that tissue damage is costing your heart. If the skin does not dent but feels firm and tight instead, the fluid has been present long enough to have triggered some scarring in the tissue. That scarring may be permanent, but the active leak that caused it can be stopped. The heart can still recover from the volume load that the swelling was warning about. The past is written into the tissue. The future depends on what question you ask at your next appointment. 8 years of a well-intentioned pill producing a problem that a different pill would not have caused. Ankles that carried the evidence for 6 of those years. A heart that carried the load in silence, because silence is what the chart rewarded. And then 1 prescription change, and a woman in her early 70s wearing her shoes again, walking the market again, sleeping without a heating pad again, existing inside her own body again in a way she had quietly stopped expecting was still possible. The number on the chart had looked perfect for 8 years. The body underneath the number had been asking for help the entire time.